When we first started working with Lynn Community Health Center in Lynn, Massachusetts, 10 miles north of Boston in the United States, we were surprised when the CEO, Laurie Berry, took us for a walk around their community, the areas around the community health center itself. So this was an unusual Gemba walk for John Shook and me. We learned who their patients were, what their needs were, and what value the community health center hoped to offer to this customer base. So after this initial Gemba walk through the Lynn community, as well as through the community health center, John Shook and I, as I said, agreed to work with Lynn Community Health Center. Now, Laurie Berry wanted help with their productivity issue, and she was very, very supportive and really believed in the lean way as it engaged the front line, but she didn't necessarily personally participate in any of this activity.
But it's interesting, and that is maybe a free association, but until Kim Eng and Alice Lee became involved with the health center, I hadn't thought of lean. I thought of lean in a different way, as kind of a more of a process improvement method. There was just an outgrowth of some of the work that had been done by the Institute for Health Improvement. But the way they think about it is much more about staff development than it is about, or maybe it's as much about staff development as it is about improvement. And that really sort of, that was an eye-opener for me, because, you know, for years I've been trying to think about how do we engage staff in improving our systems. And what they brought an approach that really seemed much more effective than anything else that we've tried. And we've tried a variety of things over the years, because, you know, we're always trying to respond to patient concerns about long waits or not being able to get in on the telephone, or so there's been systems issues from the beginning. You know, if you think about an organization that over 20 years went from 6 million to 80 million, you know, growth creates operational creakiness.
My weekly conversations with Laurie, the CEO, consisted of this discussion. She was afraid that if she freed up the clinician time, the productivity issue would get worse. And as we say, no time equals no improvement. And she understood that, but she was still grappling with, how do I tackle this? How do we fix the problem without making the problem worse?
I could see that there were so many different people in the health center that contributed to a visit, that the coordination, the communication, the whole process, there are so many things that could go wrong, and frequently did. I was always just so relieved when I heard about a fabulous patient visit where everything went right. And the reality is that in healthcare, we tend to think about our doctor as being the main person that, you know, contributes to our visit, but actually the doctor is only one small piece of the visit, and the staff, who are, some have a lot of training like nurses, some are, this is their first job, those that register patients in the beginning of the visit, the staff that coordinate a referral to a specialist, all of these folks make a major difference in how the visit will go. So really what impressed me about Lean was this whole idea of developing staff. It wasn't just about improving the process, it was really about developing staff and getting them engaged and enthusiastic about the work. And, you know, from the beginning of our work with Lean, that was what impressed me, is I had enthusiastic staff at every level, where before I had people who were looking at their watch, you know, when is it time to go home, you know, sometimes looking a little less happy in the workplace. This was different.
The team was astonished to see how small issues could add up to big wait times for our patients. And in fact, when they started creating their A3, it was very much around problems they were internally having. And after many discussions and a little bit of coaching, they understood the problem is, why do patients wait? It became that simple. That question, why do patients wait, informed everything they did. They met weekly, 3 hours a week, because again, Laurie, the CEO, was concerned about the time taking these clinicians out of the work to study this problem, as she didn't want this productivity issue to get worse. So we had 3 hours a week. And in this short time together, the team started to understand that the processes were not designed from the patient's perspective. And so our job was to assist in their understanding of the current condition. So in 3 hours a week, within 4 months, they had astonishing results, running many experiments, learning, and then shifting their experiment to learn some more. Here are some of their PDCA sheets they used to document what their next move was, why, what they expected to learn, what they actually learned, and then, therefore, what was their next step. True PDCA approach. Now, we use these sheets to help them more rigorously document their thinking and to share with other clinics or even other team members, and made it easier. They have every single one of these PDCA sheets since the beginning, since the time they start. And so here are the results within 4 months.
Welcome to Blue Team Patient Flow. So this is the patient walking into the central lobby. They are now getting greeted by the central registration greeter, who takes down some brief information and then finds an available receptionist so the patient can have a full registration. Now the patient is sitting with the receptionist. The receptionist is checking insurance, verifying address, all demographics are up to date. This can take some time. This is not a fast process, although it may look fast here. Patient's phone numbers change. Things are always changing, and so that can take certainly longer than what it's taking now, which is less than 4 minutes. The patient is given a blue slip, which is a piece of paper that has their name on it, has their appointment time. It tells them to go to the blue team. As you may have noticed, there is one greeter. So on a Monday, you can come down to the central reg area, and there could be a backlog of patients, maybe 10, maybe 20 patients. But the check-in was another improvement that required some changing of roles. But the idea is that the patient has 2 check-ins at Lynn Health Center. One is downstairs at central registration to get the demographics right and everything. And then the second one is on the team. Okay, so patient's on the blue team now. There is a symbol and a sign that's in Spanish and English to tell them to put their blue slip in a basket. And the blue slip serves as kind of like their passport to different parts of the visit. Keeps track of what's going on. The receptionist uses that blue slip to then alert the clinical assistant that the patient actually has arrived on blue team. It's a key update. The patient is now waiting for her name to be called.
So, taking the blue slip, writing down the time that I'm calling the patient in.
Did we say that our wait, so maybe we just want to make sure we capture the idea that we have a goal of patients waiting in the exam room for less than 10 minutes before they see me. And so we have a visual board that's pasted on the wall on every teamlet that shows, and we collect those blue slips. We use the blue slip as a tool to record different times of things happening. We collect these slips and we put them in little pockets that say, we have a 5-minute slot, 10 minutes, greater than 10, and then greater than 15 or something. So we can visually see during the day actively how many patients are waiting at different times.
And then to the exam room, verifying information, this is where the vitals happened.
But again, this is a key point to say that previously the clinical assistants did not have a ability to enter information directly into the electronic medical record in the exam room. There was a lot of writing down on paper, taking it out to the desk area where they had a laptop or desktop, and then going back to the exam room to enter more tests or to do more tests. And it was a lot in and out of the exam room. Whereas now, everything is done in the exam room. So Dolly is checking vitals, she's entering those vitals directly into the electronic medical record. And she may also enter some point of care testing, so like A1C, mammogram tests, anything else that she may need to do, which then preps the provider knowing that those tests are being worked on already or have already been ordered by Dolly.
Also vaccines for the nurses if the patient needs vaccine.
As you-
Also checking to see if there's a vaccine that's needed. So I just took the blue slip. Probably right now I'm reviewing it with the nurses that the patient needs vaccine.
Oh, Holly, I didn't get
The nurse is going to take the blue slip and
32.
review it, order it.
Yeah.
Patient's waiting for the provider.
Now I'm here, I am entering, I'm looking at the medical record, I'm seeing the vital signs that Dolly already entered, all the tests that she's already entered, they're ready for me to look at. Some of them may be resulted, some of them may still be waiting to be done by Dolly. She probably went and did those right now. So it's not like Dolly's not doing anything right now, she probably went around the corner, is doing some testing in our lab that's on the floor, meaning point of care tests that they can be done on site. So I'm talking with the patient, I may do some physical exam briefly, know that the blue slip Dolly and the nurse communicate with about the vaccines. And the provider doesn't have to be involved with that process, which was a pretty big shift on Blue Team for a while. But the patients really appreciate it, because previously the patient would be waiting until the end of the visit. When I get done with all my lot of work that I need to do for the patient medically, the vaccine might be the last thing I do. And so then the nurse will do that at the end. It may take the nurse 15 minutes, 20 minutes to get all the vaccine stuff. So the patient's waiting in the exam room for a lot of time with nothing going on.
And they would leave without their vaccine, so they don't want to wait any longer.
Yes, patients actually open the door. I remember patients opening the exam room door and saying, you know what, I just got to leave. And they would just walk out and say, I can't get my vaccine. That would happen not infrequently. And so, again, the idea was that the nurse feels comfortable and the provider does not feel any intrusion with the idea that the vaccines are happening in flow. So I'm doing my exam, I'm talking to the patient, I say, oh, hold on, Mrs. Smith, we have your vaccines here for you today, and we keep rolling through the visit. And you can see that happened just a few moments ago. The clock on the wall, you'll notice, is a tickless clock. For those listening, does not tick, so patients don't feel that like sensation time is passing by. It's a funny thing, but anyway, Kim Ann came up with that. It was a great idea. So now the patient is waiting. I just went out to the front desk. I'm finishing my note.
So I'm coming in with the after visit summary. I'm reviewing, just briefly what the doctor went over with the patient, checking out the patient.
Because checkout has been a revolution on Blue Team. We're trying to spread it to the other teams at Lynn Health Center. So the first thing was that we had to get agreement from the clinical assistants that they found that to be valuable, right? The idea that the patient can leave Lynn Health Center with an appointment in their hand to say when they need to come back. Previously, what happened?
They would leave without an appointment. If they're so used to it, we're telling them we'll call them back with an appointment, or someone will call them, or they have to call back to schedule their follow-up appointment.
So some patients who I would have written down on my after visit summary to say I expect the patient to come back in 2 months, and that's actually in the computer and it says that. But when the patient gets that piece of paper, they may decide that, you know what, I don't have time, I'll never remember to come back in 2 months, I'll call you when I can or something. There's no real concrete appointment set. From the patient's perspective, bringing the care to the exam room, to the patient leaves with the appointment.
A key team member for the Blue Team Model Clinic work was Dr. Nick Urbanchik. He is the medical director for this clinic. Now, when I first met Nick, he had much to say. He told me about all the problems, and it seemed that he was waiting for others to take care of them. Administration, his boss, the chief medical officer, the performance improvement person, everybody else but himself. And so I knew, as always, that we needed to create a focus for the team members to own these problems, and so they can solve them if new problems come up, and they can sustain the improvements that they've created, but more importantly, do PDCA and continually solve their own problems. Now, this may feel slower to create ownership and build capability of all of these key team members, and for them to do the same for their direct reports, but this is part of the key to sustainment. And so I encourage everyone to spend time building capability at all levels as you solve a long-standing business problem. Now, building capability and ownership, even through a lot of resistance from team leaders and team members, might feel difficult and even feel long. Like it would take a lot longer than just doing it a different way. However, if you're looking for a sustainable model, one that continues long after you're gone, long after the coach is gone, you need to spend the time to build this ownership and build this creativity so that these team leaders can do the same with their team members. That's one of the keys to sustainable improvement and continuous improvement. Over time, this approach of focusing on building ownership of the problems and building capabilities for understanding these problems and solving these problems, creating experiments to solve these problems, Dr. Nick Urbanchik began to mentor and coach his team members.
And to give you a little sample of our workplace culture, we thought we would just give you a little blue team cheer. 3.
Blue team rocks!
Woo!
You saw the video with Nick and Dolly, one of his medical assistants, talk about the journey of the patient. Here's another video of another team member that Nick helped to coach and teach, Denise.
My name is Denise Cabrera, soon to be Denise Fernandez when the papers come in. And I've been in LCHC for 4 years, I want to say in November. Apart from being a clinical assistant up here, I'm also part of the Lean team. I was the first clinical on the Lean team. And then Lean, we're leaning the way. We've been doing all of these experiments, starting from 2 years ago, a year ago. I don't even remember, it's been so long, I think a year ago. Trying to cut down patient wait time up here, making sure the patient has the best experience up here. And our little cheer is Blue Team Rocks. So that's what we're trying to prove here. We really do rock. We're the best, so that's a blue team. It's a giant, big family up here. Giant blue team family.
Denise here, you can see her passion and ownership of a key problem. Now, the problem itself wasn't that challenging for maybe a so-called lean expert. But again, the key is not to directly solve the problem because it's easy to solve, but to create capability and ownership in the team members so that they can try and test and learn what they can do to solve these small, everyday problems. Here's Denise talking about a problem-solving activity that she led with her own colleagues.
So the flags, we had like 5 different iterations of the flag. And I'm going to introduce you to our flag system. Before, what we used to have were 2 flags right up here, 2 plastic little markers up here. They didn't really have much meaning. We didn't really use them. We didn't really know how to use them. We came up with this flag system. Basically, it just signals what we need inside of the room. When it's straightforward like this, it means that the provider is needed inside of the room. And when it is tilted up just like this, that means that the provider is already inside of the room and the session, well, it's in session. Before, what we had were these flags. They were square all the way through. And when we used to hang them up here on the door, they used to actually fall. They were never really steady. They also crashed against the wall with the corners. So we did a couple of iterations on them. First, we cut the corners. We made them into a circle just like this one that you see here. And then also what was happening was these little magnets were a choking hazard for children. The children would either pick them up, swallow them, they can potentially choke. And so we tried to do staples right around the magnet, but we still noticed we could still pick up the magnet and take it off. So what we did was also hot glue gun it right around. So when we got these flags, they have the staples right around, and they also have the hot glue gun. Now they don't move at all, and they're pretty steady. And right now, with the circle and with the magnet, now that they're not moving, they are flexible enough. They stay in place when we need them. And basically, these flags are now being used. We know what is going on in the room and when we are needed. So there are signals of when we're needed. We're not looking around for each other. Okay, so right behind me, we have the provider flag up, meaning that the provider is needed. And then right across from that room, in room 30, we have the nurse flag up, which means that the nurse is in there. And the checkout flag is straight out. knowing we now need checkout. Before, the nurse would ask the patient if they're all set, and now the nurse doesn't have to ask because we know with the flag that they will still need checkout. So this flag system has helped us know what's going on inside the exam rooms, and as soon as the signal goes up, we know where we are needed. And this has helped our overall goal of reducing patient wait time. We didn't make anyone do this. We started it with one provider and let people pull, see if they wanted to try it, and we found out a lot of people actually like this. More and more people started asking me to make them a set of their own flags so they can start using it. I became the flag mom, and now everyone in the department is using these flags, and also other departments are coming to me asking them for the proper training on how to make their own flags, and so they have picked up the flag system and created their own iterations of their flags. Thank you. Feel free to come over anytime that you guys would like to come and see our beautiful flags, and also to see other experiments we've been working on. And also, if you guys ever need a set of flags, I'm the flag mom, and so I'll make them for you.
Because of the work she did here, her role was recognized officially, and she is now the lead medical assistant for the entire community health center, and it's given her prominence and even more confidence as she continues to teach problem solving to her peer colleagues.
Like even now, we're still making flags. Like the pharmacist now has her own set. BH has their do not disturb flags. Coumadin has their own flags too. Because of that, PD came over. I believe they were one of the first people that came over, and they're like, well, we want to make the flags. How do you make them? What do you do? So I spent half a session trying to help them out with their flags, and then they created their cute little flags with little stickers on the side. Because they're PD, they gotta be little cutesy flags. And just the other day I was strolling around in OB, and they have their flags now. And then the Rose team came by maybe like a month or two ago, and I spent half a session too with her making her flags, and I was like, if you have any questions, email me, ask me. And so Dan from there actually emailed me too, and I'm just like, oh, I'm the flag mom. They're my babies. So. It was Aurora's idea, but I made them, so they're my babies.
Creating this engagement at the very front line, and these medical assistants are absolutely at the front line, is key. Her confidence grew and her passion grew around solving problems around the patient wait time. Remember, the problem statement was, why do our patients wait? At the Lean Enterprise Institute, we use the Lean Transformation Framework to think about organization transformation. There are 5 dimensions. I'll pose them in terms of questions. What is your purpose or the problem you're trying to solve for your customers? How do we do and improve the work to support this purpose? How do we develop the capability in its people who do the work? What management system and leader behaviors do we need to support the people doing the work to solve the problem for the customer? And lastly, what is our basic thinking? So as we use the Lean Transformation Framework with organizations, we ask what the challenges are. And we have surveyed thousands of people over the years to ask this question. Which of the 5 dimensions is the most challenging? Which is the most important to get right? And which do you personally struggle with the most? So the 5 dimensions again: purpose or alignment around the problem to solve, doing and improving the work, developing capability and its people, the management system and leader behavior, and of course basic thinking. So every single time we surveyed, about 40% of the surveyed people respond leader behavior. Not necessarily the management system, but leader behavior is the single most challenging element of the 5 dimensions. Some of the challenges in healthcare unique to this industry is we have multiple competing missions. So at the same time we're providing care to our patients, we're teaching the next generation of caregivers. At times this conflicts. It results in duplication of services, service times being longer than needed, even valueless service from the patient's perspective as we teach residents and interns or nursing students. Our defects can be harmful to the patients. We can hurt our customers. And of course, what we hear over and over again is that we don't have enough providers, resources, time, we always claim we don't have enough. So Dr. Kiami Mahania was the Chief Medical Officer, the CMO, at the time that we were introduced to the Lynn Community Health Center. Now, he was very standoffish. He observed from the sidelines, did not actively participate, although he was the manager of Dr. Nick Urbanchik, who was the medical director of the Blue Clinic. Kiami started to engage a little at a time, and he became the new CEO, Chief Executive Officer, when Laurie Berry retired. Some of the challenges Kiami had was shifting from where they currently were to a lean thinking leadership team. Here he is talking about that dissonance or that shift that was so challenging for him especially, as well as for the whole leadership team.
So in medicine, there's something that's called motivational interviewing, where you're supposed to introduce dissonance in a patient. Like, you don't confront them. You sort of say, you know, you want to quit smoking. Or what do you think about smoking? And if the person says, I love it, I'm going to die with a cigarette in my hand, you're like, okay, well, move on to the next topic, right? But if they say, oh, you know, I would like to quit, and you say, why would you want to quit? You know, like, sort of, so they get to sort of confront themselves. And I think what's happened through you and LEI and Kim is that you've introduced a dissonance between what we say we want to do. Like, you've heard us talk in the meetings. Like, if you hear us talk in the meetings, we are like lean 100%. You know, like, we are like committed to learning about lean, using the lean language. We can talk the basics of the lean language. But our actions are still not there, right? But so what's happened in the past year is that there's now dissonance there, right? We know we should be doing this, and we're struggling, and occasionally we do a few things that are sort of more in that setting. So at least now we know that there's a problem with the way we operate. There's a problem with our decision-making process. There's a problem with our huddling in our secret chamber on the 4th floor and coming up with, I mean, we come up with detailed workflows that the frontline are supposed to do. Like, printed out standard workflows, right, with just us. But now there's a growing dissonance, right, that, you know, we not supposed to do.
As Kiami Mahania, the new CEO, continued to learn more about lean, he had a growing dissonance or dissatisfaction or awareness and became more and more uncomfortable with what was going on. As he says, we say we're lean or doing lean or thinking lean, but our behaviors say otherwise. So Kiami continued to struggle about being the boss, how everybody came to him looking for answers.
The Community Health Center is the health center where the senior managers have the most authority and power, right? Like, I was really shocked when I came here as CMO. Here, the CMO is the boss, you know, like of the, and they want you to be the boss, right? It's a strange, and so I struggled with that the first few months because, you know, I'm thinking, you know, the boss is a facilitator, the boss is somebody who allows you to accomplish the things that you want to accomplish, make sure that you have the tools, sort of related to lean. I didn't know anything about lean before I came, right? But sort of my general philosophy was, my job is just to make sure that they have what they need to do their jobs and make sure they're not unhappy. And I came here and they're like, what should I do? What are the rules? You need to confront the other chiefs. You need to protect us. You need to be like the big mommy, like, right? You know, you have to. And so that's the traditional role of each individual senior leader at Lynn. They don't belong to the senior team. They belong to their department. And their job is to grow the department, to protect space for the department, to get money for the department and resources for the department.
Kiami is starting to ask himself, as well as his leadership team, what else do they need to do? How else can they engage to make this leap, to close this gap, to become a lean organization? And is this a small change or transformative change for the leaders and how they behave.
I think that there's a recognition that we need to change. And if you interviewed each one of us, we would all say, we need to change. We need to figure out how we're going to put in place the things that we've theoretically been exposed to. How do we put it in practice? Because right now our instinct is still to drop into authority-based decision-making when push comes to shove. We're really struggling there. So when it's something that doesn't matter so much, we can do it. Right? So we decided, oh, let's do a model team. It's like, okay, yeah, let's do a model team. That sounds good. Right? Because it doesn't threaten anybody, right? Like it's existing on its own, and we can always contain its virus of improvement if we need to, right? We just destroy it if we have to.
Kiami firsthand started to understand how hard it was to change and acknowledged the need for change, not just for himself as CEO, but for his leadership team to set that expectation and direction for the entire team. There was a loss of control, his team stated,